cycle 6 because we want to check for the mammogram and also ultrasound. And best where we can do the surgical surgery is after the 3 weeks to 4 weeks, because within that 2 weeks, patient still have side effect or any for example, like bone marrow suppression from the chemotherapy itself. So that's why we have to ensure that this period of time, we give some time for patient to settle down until, for example, for 3 to 4 weeks, then we can subject patient for surgery.
Very important. Sometimes that you do new adjuvant treatments. And then somehow the OT, somehow you don't have the OTs. So that's why we see that cycle 3, cycle 4, cycle 4.
Cycle 5.
So that we can book way ahead the amount of reserve for them. So this, I think, a very important point. Because if you don't do the surgery after that 3 weeks or the 4th week, we do it on the 4th week, right? Because we...
3 or 4 week. Yeah.
You all can be smart, you can do exactly 3 weeks. No, we should do it. So 4 weeks. But if you book them 3 months ahead, for sure you will have the list. If you don't book them then, you'll find you struggle to find them at least. So please, if you don't do it at that time, you know what will happen? You'll go again, because you didn't take more anymore. Right? I think that was something I thought it would be important. Thank you very much, thank you for Salina. Okay, welcome our final speaker for our morning session. I welcome Ms. Salina from PhD AA Batam.
Bismillahirrahmanirrahim. Assalamualaikum. Assalamualaikum and very good morning. Thank you, the organizer, for giving me this opportunity to present this topic, axillary management in breast cancer post Z011 and AMAROS trial. So you can see, right? Everyone is prof, consultant. I'm the most junior, I think. Should ask any otai to present this topic, I think, but I'll try my best to deliver the speech. So I hope that most of you familiar with the Z011 and AMAROS, which means this thing we discussed about the axillary nodes dissection versus the sentinel lymph nodes biopsy. So what happened after Z011 and AMAROS trial? As we know that the lymph node status most important for the prognostic factor, and it estimates the risk of breast cancer relapse, and also is considered for any decision making for adjuvant treatment. So as we know that the axillary lymph node dissection has been part of the breast cancer surgery since the introduction of the radical mastectomy for the regional control of the disease. And actually this procedure is without side effect such as a lymph edema, shoulder deformity, and as we know that we call it axillary web syndrome. So the sentinel lymph nodes biopsy alone is the accepted management for patient had a negative sentinel lymph nodes. So what is Z011 and AMAROS trial? Yeah? So, boleh pakai ini? Okay, so the Z011 is an axillary dissection versus no axillary dissection in women with the invasive breast cancer and sentinel lymph nodes metastasis.
I cannot hear.
So the study group is the woman with the T1 and T2 tumor with the clinically no palpable lymph nodes, and when they had the sentinel lymph node biopsy, the lymph node positive is only 1 to 2 lymph nodes. So they group this patient into 2 groups, which is for those who are positive for the sentinel lymph nodes, we'll have an axillary lymph node dissection, and the other groups is only the sentinel lymph nodes alone. So this patient in this Z011 trial, all patients had a lumpectomy and tangential whole breast radiation. So actually the tangential whole breast radiation they give like little bit higher up to cover at the level 1 and level 2 axillary lymph nodes. So the outcome is the primary outcome for 5 years overall survival, and the secondary outcome is 5 years disease-free survival. So they follow up patient up to 6.3 years. So we can see that in the 5 years overall survival, the axillary lymph node dissection was 91%, and the sentinel lymph nodes biopsy group 92%. And for 5 years disease-free survival, the axillary lymph node dissection 82, and for the sentinel lymph nodes group 83. Actually, this study is a non-inferior study. So for the AMAROS, AMAROS is actually stand for the after mapping, after mapping the axilla, whether we proceed with the radiotherapy or surgery. So radiotherapy or surgery of the axilla after a positive sentinel lymph nodes in breast cancer. So in this group, the breast cancer tumor is a T1 to T2 tumor, no palpable lymph nodes, and when they had a sentinel lymph nodes biopsy is a 1 to 2 sentinel lymph nodes positive. So they group this patient into the those who had the axillary lymph node dissection, and the other group is assigned for the axillary radiotherapy. So the intervention is in this study they include the mastectomy. If you understand, the radiotherapy is actually the treatment to the axilla compared to the Z011. They only give to the breast, but they raise little bit to the level 1 and level 2 axillary lymph nodes group. So the outcome is they look for the 5 years axillary recurrence, which defined as a tumor recurrence in lymph nodes in the ipsilateral axilla, infraclavicular fossa, and in the pectoral alveoli. So for the secondary outcome, they look for the axillary recurrence-free survival, disease-free survival, overall survival, and also the morbidity to the shoulder and lymphedema and quality of life. So the median follow-up was 66.1 years. So you can see that actually there is no significant difference between the axillary lymph nodes dissection and axillary radiotherapy group. So, but there is a significantly noted that there is a shoulder deformity in the, the lymphedema in the axillary lymph node dissection compared to the axillary radiotherapy. So as a disease-free survival, you can see that it was 86.9 in the axillary lymph node dissection group and 82.7 in the axillary radiotherapy group, which means there is no really significant difference because this study also non-inferior study. So what we know about the axillary management for the breast cancer. So after the sentinel lymph nodes biopsy, actually we decide for the clinical decision making for the next treatment for our patient. So when tumor deposits are found in the sentinel nodes, it depends on the nodes involvement, which means if the nodes only have an isolated tumor cell. So actually there is no prognostic importance for the isolated tumor cell. So we can assume that this IPC is a negative sentinel lymph nodes. The IPC is how we classify the ICT is actually 0.2 mm or 200 cells of a tumor. So the micrometastasis, there is a potential hazard. So that we can say that the micrometastasis is a positive sentinel lymph nodes which warrant for the adjuvant systemic treatment. For the macrometastasis, when we see that there's a macrometastasis in sentinel lymph node, initially the treatment is based on the center, the country, and also involved in their multidisciplinary approach, whether how to proceed with the adjuvant treatment for this patient. So after the Z011 and AMAROS trial, So we can see that actually we look for evidence. So actually there are so many trials that involve after Z011 and AMAROS trial to prove that actually the sentinel lymph node biopsy alone is for those who had a positive sentinel lymph node biopsy who received the radiotherapy actually is good enough compared to axillary lymph node dissection. So this study is the trend of the axillary treatment in sentinel lymph nodes positive patients who had a mastectomy. So you can see in this study that there is a significantly reduce of the axillary lymph nodes dissection performance for those who had a who had a positive sentinel lymph nodes biopsy. So, and in this study also that you can see that there is an increase post-mastectomy radiotherapy, which is from 4 to 49, increase to 49%. And from the 2019, 49% and increased to 70%. So also is in the micrometastasis patient, also they like abandon the axillary lymph node dissection, but proceed with the post-mastectomy radiotherapy. So this study is quite similar with the AMAROS trial, which was published in 2017. This was done in Budapest, I said that practice before. So for the 8 years, they follow up a patient for those who had a positive sentinel lymph nodes, whether had a axillary lymph node dissection or radiotherapy to the axilla. So they are follow up 97 months of patient. So they found out that axillary recurrence was 2% in axillary lymph node dissection versus 1.7% in regional node irradiation. So as 8 years follow up, they can see that the disease-free survival was 71% in axillary lymph node dissection and 77% in regional node irradiation. So they said that actually this study showed that there is no axillary failure for those who have received radiotherapy to the axilla. If we didn't proceed with the axillary lymph node dissection, provided we give the radiotherapy to the axilla. So this is another study, another evidence that the effects of omitting axillary dissection and the impact of the radiotherapy on patients with breast cancer, sentinel lymph nodes, macrometastasis. This is the cohort study following the Z011 and AMAROS study. So the 5 years overall survival was 96% in non-radiotherapy cohort and 93% in the radiotherapy cohort. So the 5 years disease survival was 100% in the non-radiotherapy cohort and 92% in the radiotherapy cohort. So they conclude that it is possible to avoid axillary lymph node dissection in patients with clinical T1 or T2 tumor and 1 or 2 sentinel lymph nodes positive without compromising the overall survival and disease-free survival. So actually, this study, the radiography or surgery of the axilla after a positive sentinel lymph node in breast cancer. The initial study of AMAROS was 6 years follow-up. So now they extend for another 5 years. So the total duration is 10 years. So the finding is quite similar. There is no actually, it is a low recovery rate in both radiotherapy and axillary lymph node dissection, and no difference in overall survival, disease-free survival, and the local regional control. So actually, that result was presented at the South Anterior Breast Cancer Symposium in 2018. So after 10 years, in addition with the distant metastasis, free survival, no overall survival was significantly different between the two arms. And the distant metastasis for survival was 78% among those assigned for the axillary radiotherapy, and 81% for those who assigned for the lymph node dissection. So the overall survival in these two arms was 81.4% and 84.6% respectively. So, 1.8. So actually it's quite low, the axillary recurrence in these two groups. So they conclude that the axillary radiotherapy is a good alternative to axillary lymph node dissection in this group of patients. So based on this Z011 and AMAROS and also all the new evidence with so many trials, so is there any way for us to omit the sentinel lymph node biopsy? So it's come with a sentinel lymph node biopsy versus no axillary surgery in patient with small breast cancer and negative result on ultrasonography of axillary lymph nodes, which we call it a sound randomized clinical trial. So in this trial, in the absence of why they come up with this trial, because they can see that in the absence of the advantages from the axillary lymph node dissection revealed in the Z011, so whether is it really necessary to perform surgical staging of the axilla of the axillary lymph nodes? And second, whether the imaging might replace the surgery for reliable staging of the axillary lymph nodes. So they randomized a patient, which 700 patients for the sentinel lymph nodes group, and 600 patients were randomized to the non-axillary surgery group. So the median tumor is about 1 centimeter, but the total is like 1.1 to 1.5 centimeter of the tumor. So they look for the 5 years disease-free survival, which was 97 in the sentinel lymph nodes and about 98% in the axillary surgery group. In the non-axillary surgery group, which means it's quite similar, it's not inferior. So for the relapse also is quite the same in these two groups, and also the regional relapse and also the distant metastasis, also the result is quite same. So the key point is, so the question is again whether is it safe to omit the sentinel lymph node biopsy in patients with small breast cancer and a negative preoperative axillary ultrasound result. So they found out from their study, so a patient who did not undergo axillary surgery had non-inferior 5 years distant disease-free survival compared with those who underwent a sentinel lymph node biopsy, which means that this finding suggests that patients with a breast cancer of diameter equal or smaller to 2 centimeter and a negative result of preoperative axillary lymph nodes on ultrasound can be safely spared for any axillary surgery, whether the lack of pathological information does not affect the course of treatment. So this sound trial found that the omission of axillary surgery was not inferior to sentinel lymph nodes biopsy in women with a small breast cancer and negative result on ultrasound of the axillary lymph nodes. So despite of this sound trial, actually there are few studies that related to this, whether shall we omit the sentinel lymph nodes biopsy. This VOOG 2013
to 08. Actually, this is an ongoing trial. It's quite similar with the sound trial. Also, the postdoc trial is actually quite similar with the AMAROS, but this one is still, there is no result available. So this is my conclusion. Actually, we are going towards the de-escalation of therapy, which can improve mobility of our patient without compromising their outcome. So with that.
Ladies, any questions? To Ms. Juliana?
Nice, I just wonder, what about, tumor which is more than 4 centimeter, 3 centimeter? Are you still giving SRNB? If, proven negative, in radiological assessment?
Let's say the tumor is 3 centimeter and negative
E3, more than 5 centimeter.
more than 5 negative. So based on that one, I still follow our CBG that we are not advised to do the sentinel biopsy for those who are big tumor. But for the 3 centimeter and below, I still do the sentinel biopsy if there is a negative notes before we start any adjuvant treatment.
What about Prof. Aisha? Prof. And if you practice doing sentinel biopsy in more than 4 centimeter?
Depends on the definition. If the tumor is not
This not a mic, right? It's just for recording.
It's for recording.
patient population, they include all the biological, biological subtypes of the breast cancer, which is include all the BRCA positive, HER2, and also the triple negative, and they treat accordingly. They also give the treatment include give a HER2 positive, they give the
I don't know the answer, but I think it's very important that you actually, when you want to decide if you're trying to change your practice, because one study is not there, right? I agree with that. So you need to look at other studies. So is there any
Ayah tu tengok slide pasal sebab tak nampak sana kat LCDs.
Actually, I'm looking for this. Is there any way to the result? The only trial that come out with the result is the sound trial. There was published end of last year. So the rest
Kalau
is
last tu
two
ada saya
studies
kita
ongoing.
pasal describe.
I just want
Terus
to
tak nak
see
yang
the
last
manuscript that
tu
the protocol of the study.
atau mid lah.
But the
Nampak
study
yang
is
cantik.
quite similar with the sound trial. But this is the only trial that come out with the result. Which means we are nowadays mainly towards the axillary surgery. You see few trials, because still we can see that English quite less time.
Because we can see that in the European, we start the center lymph biopsy post graduate treatment, but still in Malaysia, we do not look at this.
I think it's good to know all this trial, but to follow the trial or not, you have to take a risk, right? So that's why Prashan is asking you, are you following the trial or not?
At this moment, no. At this
No,
moment,
you
no.
just wait for the
Yeah,
next trial.
because this,
You just wait for a few more trials to come, and then if let's say you are confident enough, we may start doing, but of course you have to select your patient very well.
so actually,
Just follow the gatekeeper.
yeah. So actually, this topic, I just go to the committee surgery note that we are aware this is happening outside Malaysia. They are trying to de-escalate the surgery. I think it is Salina. So when we move on to our next case discussion, information.
I just want to ask, the opinion from the members. In the era of this accelerating, surgery, now we have,
When I start, I don't have to press anything, right? Next time.
that we do surgery by key. But somehow technically issue, and somehow it's not, we cannot detect the surgery.